Welcome. My name is Traci, and I'm here today with Vicky Howard, Product Manager and Clinical Support Physicist here at Standard Imaging. Vicky and I are delighted that you're here with us today to talk about innovation in patient-specific quality assurance. Both of us having spent most of our careers in the clinic, we've had the opportunity to witness many incredible advancements in rad-onc through the years, and we're so excited to have you with us today.
Yeah, good morning, everyone. Yes, certainly it's been a remarkable journey for me, especially in medical physics. No longer is quality assurance a task of night mice physicists, which I was one of them for many years. Physicists are now an active part of direct patient care through their involvement in special procedures. But the downside is that these added responsibilities, as well as staffing shortages, significantly increase a physicist's workload. So in the face of these challenges, physicists really need to be empowered to work smarter, not harder.
Yeah, they certainly do. And fortunately, Standard Imaging is keeping pace with these with the current times and offers comprehensive solutions that help streamline and automate patient QA. Yeah.
Yeah.
So a couple of housekeeping notes here from our team. Just for those of you who are in attendance, today's webinar will be recorded. You'll receive a link to the recording as soon as we're finished, but you can also access this recording and all other previous webinars on our website under webinar recordings, www.standardimaging.com. As far as entering questions in the GoToMeeting dialog box, please feel free to do so anytime during the presentation. We may not see them right away, but we will have time at the end for sure for Q&A, so we'll have an opportunity to address each question, but feel free to do so at any time during the presentation.
Great, thank you, Traci.
Absolutely.
So yeah, Standard Imaging offers a comprehensive set of patient QA software solutions that span from our IMSure 3D treatment plan second check software to our Adaptivo EPID-based patient QA solution and LinacView, which is our log file-based machine performance solution.
From my past experience in the clinic, Vicky, patient or plan-specific QA usually just involved a second check of the treatment plan and perhaps a treatment patient QA and a phantom for more complicated plans. Why do we need more comprehensive solutions in today's rad-onc world?
Right, yeah, traditionally patient QA was basically consisted of usually a low accuracy 1 or 2 dimensional second check of the treatment plan, and perhaps a pre-treatment plan delivery QA using a phantom or measuring device for some more complicated plans. But after the plan was QA'd in that way, it was basically considered good to go for the full course of treatment. And most other QA was retrospective in the form of weekly chart checks by the physicists, chart round reviews by the physicians and other clinical staff. But really this approach can be very subjective, and it's not very reactive to changes or issues that can happen during each delivered fraction. So there is a growing need for in vivo QA for every fraction, and that's becoming more and more important, especially with the trend towards dose escalation and hypofractionation. You know, actually the World Health Organization and International Commission on Radiological Protection is highly recommending in vivo QA for patients, and this has become required practice in many European countries.
That makes sense. How do these three solutions complement each other from the patient QA perspective?
Sure. Actually, I think the illustration on the left, although very simplistic, is a great way to demonstrate how these fit together. So we have IMSure 3D, which would be represented in orange, and that provides a highly accurate 3-dimensional double check of the treatment planning system calculation prior to the treatment's first fraction. So with that, we gain accuracy and 3-dimensional view of that accuracy. LinacView is represented in blue, the accelerator there, and it provides both the therapist and the physicist with alerts and tools to ensure the Linac delivered each treatment delivery of the plan as expected, and this happens as soon as the treatment is delivered. And then lastly, Adaptivo is represented by the green patient and the green EPID panel. And this software provides both pre-treatment and in vivo QA options for every fraction, and this can be used to highlight potential changes in patient positioning and anatomy on a per fraction basis.
I appreciate the 30,000 foot overview there. It's really interesting to see how these three are working together. I know there's a lot that goes into each one individually, but to see them working together is really something. Can you give us more details about each one individually?
Sure, that's be happy to. So I'll start with IMSure 3D. So this is the gold standard for treatment plan double check. As I mentioned, it's miles above previous options, which just looked at, you know, one-dimensional or two-dimensional comparisons. And really, there are three key strengths of this software. The first is the Monte Carlo level accuracy. Second are the fact that these calculations are extremely quick. And third is absolute automation, meaning it's very seamlessly incorporated into your existing workflow. So I'll dive a little deeper into each one of those. So really, one of the key strengths behind IMSure 3D is the SIMOCA Monte Carlo algorithm. The fact that Monte Carlo is the gold standard for radiation therapy dose calculation is not a new idea, but it is new to treatment plan double checks. The primary reason we didn't have Monte Carlo in every clinic in the past was due to calculation time and also hardware costs to support that. So to meet that challenge, the developers of SIMOCA focused on optimizing every element of the Monte Carlo algorithm to really accelerate the computation times without relying on really expensive hardware or GPU cards. So, moreover, the SIMOCA algorithm is well proven as it has been associated with many peer-reviewed publications in both academic and commercial settings. And, you know, as a physicist who spent many years in the clinic, when evaluating a new product, I really wanted to see, you know, those publications from independent sources. So that is definitely backed up with SIMOCA. And next is the beam modeling expertise and precision. So really that kind of sets the bar even higher for IMSure 3D. With our proprietary beam modeling process, we can support conventional Elekta and Siemens Linacs, Varian, which includes Halcyon and Ethos, Accuray tomotherapy, RadExact, even CyberKnife ZapX, and Unity is a work in progress. So the whole gamut almost of delivery options we can handle. All right, so the next would be the ability for these calculations to happen fast. Nobody wants to wait around for a secondary check. So through proprietary multi-core CPU-based, we can reduce calculation times in general to around a minute. So I'll give you a little bit of a closer look at some of those. So here we have an example. First on the left side, we have a fairly basic prostate plan, 3mm voxel size. And this calculation time happens in less than 16 seconds. So, you know, before you can blink, pretty much it's done. And to point out, the accuracy of these particular examples is 1%. So moving on to something a little more complicated would be, you know, prostate with nodes. And again, similar voxel size. And in this case, it's still just less than a minute. A more complicated plan, let's say we want to reduce the voxel size because we have higher dose gradients, we're still looking at less than 2 minutes for computation time. But one thing to keep in mind is that ultimately these calculation times are usually invisible to the user since it's all happening automatically behind the scenes, totally hands off. Typically, when the user sits down to interact with the software, the calculation is already complete. The physicist is alerted by an email when the calculation is done and the report is ready to review. So the only time they would really be aware of this real-time calculation performance is if they're sitting in front of the plan and they want to change something, such as uncertainty or perhaps the calculation grid. So this will force a recalculation in real time, but really this scenario isn't the usual workflow. So. And then lastly, I'll talk a little bit about the automation. So the application is entirely browser-based, and has no local client, which means IMSure 3D is accessible anywhere on a computer that has access to the network. So with the structure of a lot of departments these days, where you have remote centers supported by maybe a core group of physicists, that is very important. So upon logging in, the user will see the patient work list shown here on the right. This shows all the patients and plans associated with each patient. You could have multiple plans that reflect different versions of the plan with different calculation settings or boost plans. The plan status indicates which plans are awaiting review and which plans have been completed or approved. And then we have easy to use tools on the right for archiving or auto archiving patients off the work list to save on storage and declutter your work list. So this is a very user-friendly, super easy to learn software. So easy to incorporate into your clinic and train staff. The workflow to get to this point is fully automated, as I mentioned. A DICOM export from your treatment planning system will queue the calculations. There's parallel processing to optimize that throughput. So if you have a very busy clinic, you're not going to have plans waiting in line for calculation. And once the calculation is done, the workflow is automatically updated and the user can configure auto email distribution to let the appropriate people know when calculations are done. So not everybody necessarily needs to get an alert. Maybe you have one particular physicist supporting one clinic and they're the only ones, maybe a backup, who needs to be alerted for that. So it's really funneling the information where it needs to go so physicists can focus on what they need to focus. So plan quality review can be fully customized within your clinic with configurable templates. There's really a comprehensive list of measures and defined metrics that can be used, and these are very similar, exactly the same as how you might evaluate the original plan in your treatment planning system. But within IMSure 3D, you can look at those parameters, comparing your treatment planning system results with the IMSure 3D Monte Carlo results, look at any differences and set your flag tolerances and that sort of thing. Even more helpful is we do have an interactive image viewer and DVH comparison. So this can really help expedite dose evaluation and analysis. You may have an overall gamma that's kind of borderline, but you really want to be able to look and see, okay, well, where are those disagreements? Are they in a clinically significant area, or is it in an area that doesn't matter so much? We have some wiggle room. So this image viewer will allow the user to scroll through slice by slice, and even with the structures turned on, they could see exactly where those dose disagreements existed. And then as well, we have the DVH display, which compares both the treatment planning system and the IMSure 3D distribution, so you can hone in on details there as well. So, very easy to use, streamlined workflow, easy tools, a lot of information at your fingertips, fast and easy.
It truly does seem really fast. Actually, I was going to make a comment about that, the time savings there, but then also the insights into keeping everything running super accurately in such a fast way. That's really nice for a clinician, yeah?
Yes, most definitely. And again, as I pointed out, physicist workload is not getting less, but we do need to give more information, very streamlined and easier and quicker. So,
yeah, that is absolutely the truth.
Yes. So that kind of leads into our next patient QA software solution, LinacView. So LinacView, as I mentioned, is a log file machine performance QA tool that provides automated analysis, clinically relevant alerts, and customizable notifications for every fraction of a patient's treatment. So, IMSure 3D covered the pre-treatment QA. Well, this is really looking at every fraction. So daily delivered versus expected fluence comparisons can be fully integrated into the patient's treatment workflow. So there are no extra steps that need to really happen on the clinic side to get this information. There's also automatic machine performance analysis to assess treatment delivery issues. And this can be used by the physicist to really better predict and prevent future machine failures. So just to kind of give a more detailed look of what the therapist might see, at their treatment console. So there is a computer that would be set up at the treatment console, and it will alert the physicist, or sorry, it will alert the therapist and the physicist if there is something that is out of tolerance. So as soon as the treatment is complete, the details of the treatment delivery are displayed in tabular form, and its calculations happen very fast. And so the alerts would be something clinically relevant. So for the therapist to really see more closer details, all they would need to do is hover over the alert, and then they can see exactly what the issue was, and that just gives them some basic level of knowledge. Now, physicists are automatically notified via email as well, so they then have the opportunity to follow up and look at a much more detailed view of the delivery. So here's the analysis summary page the physicist would look at. The tabs are color-coded. There's a lot to look at here. The black are delivery data, but they don't have any analysis constraints associated with them. They're basically just kind of allowing the physicist to come and look at trends and actually be able to follow through some of these movements through a patient-specific delivery. The second are the green tabs, and these are tabs where there is an associated analysis. Green means passing, orange would be an alert, red would be a failure. You can also see in this summary page what the tolerances are for each of those, so you can kind of, in just a quick overview, assess some of those things.
And it's quite a bit of information, but how helpful to have a little peek inside each fraction to see how things are really progressing, a constant pulse on the success there.
Right, exactly. And if you notice here, there's a fluence versus plan tab. So that's really helpful just from patient-specific delivery QA perspective. So here, fluence is determined by color painting, with a color being proportional to the total monitor units for each control point. The corresponding gamma analysis can be overlaid on the treatment field shape, and the gamma spread or distribution can easily be viewed as well. So pointing out that this isn't displaying dose. We don't display dose because we really feel adding in a separate dose calculation algorithm to this process would really add uncertainty to the fluence comparison. Since the dose calculation algorithms differences between planning system and what IMSure 3D, or LinacView might use, would really just fold uncertainty into these results. So instead, we provide the user with the option to export an RT plan file back to their treatment planning system. So if they want to compare delivered dose versus treatment plan dose side by side, they could easily do that using the same algorithm that their planning system uses. So it just puts those two comparisons on the same playing field.
Oh, nice.
Yeah, and this could really also be used for adaptive workflows. So I'll talk a little bit about that too.
Yeah.
Selecta Unity QA is a bit of a challenge. So I don't know if any of you have those in your clinic, but it changes the workflow that we're used to. So real-time adaptive workflow for the Selecta Unity limits your plan QA options. There's no pre-treatment plan QA possible because the plan is optimized and created while the patient is on the table, and then they move on to treatment. So each fraction is basically like a new plan, and the physicist is only able to measure and perform quality assurance checks after the treatment is complete. So LinacView really allows for a quick, real-time, immediate evaluation of the accuracy of that treatment as soon as the treatment is complete. So we've had a lot of interest from our Selecta Unity customers for this as a solution.
It seems like it would be incredibly helpful for those working in the fields to be able to see those things immediately.
Exactly. Helpful in many cases, like not just for the adaptive workflow, but also, like I mentioned, in addition to the patient QA, the machine performance QA is really valuable to give physicists earlier insight into potential things going on with the Linac and hopefully avoid downtime, because we all know downtime just is stressful on the entire clinic,
Oh
and
my goodness,
let
yeah.
alone for the patient to be missing treatment or get up in the middle of a treatment and not be able to complete it. So.
Oh, for sure. These seems like, I know I hate to use a buzzword, but risk management has been everywhere in our field recently, and it feels like these things so far tick all of the boxes for a program looking to control that risk management factor.
Yes, definitely. I mean, I feel like physics and radiation oncology in a whole up till now has done a great job controlling risk management up to the first fraction, and then the rest is really tricky for facilities to standardize the risk management process during daily treatments. And a lot of time it's a lot of checklists in place, and it's still hard to take that human factor out of it. So this as a solution really helps empower facilities to take the human factor out of their risk management and make it more quantitative and not just qualitative. So.
Definitely
That
interesting.
leads us into the last software solution for patient dosimetry, our Adaptivo.
Yes, I'm so excited about this final piece of the puzzle, especially since we just released a new version of Adaptivo for our customers. I'm really thrilled to learn more about this part of what we're doing here.
Yeah, me too. The new version has many excellent additional features that our existing customers were very excited about. I'm not going to dive into all those new features today, but I'm happy to arrange a demo for anybody who would like a closer look at the new version. As I previously mentioned, with the trend towards dose escalation and hypofractionation, the ability to perform real-time QA for every fraction that fits into your existing workflow is really becoming more and more important. Adaptivo's automated workflow and familiar analysis and evaluation tools make it really easy to incorporate into your clinic. So, you're looking at all the same similar tools that you're used to. So it's something that can, easily be incorporated. Adaptivo has 3 available modules. All 3 can fit into your workflow. We have the pre-treatment module, the daily 2D in vivo module, and the daily 3D adaptive module. Today I will only focus on a brief overview of the daily in vivo module, but first I want to quickly review some of the limitations of traditional QA workflows that still a lot of radiation therapy clinics follow, so that you have a better appreciation of really what Adaptivo offers. So what we're all very accustomed to is the fact that pre-treatment QA, can be performed either in air or in a phantom using film, a detector array, or some sort of EPID field portals to verify field shape and dose fluence. So these options have been useful over the years. However, they all leave out one very important factor: the patient. When it comes to QA for daily treatments, most are either insensitive to patient anatomy or weight changes that can change the dosimetry. And some of these are like surface-guided radiation therapy, where if a patient loses weight, you may not really notice because you're just setting up to the anterior surface of the patient. So you could kind of miss out on those changes with that. Or some of the other solutions for during treatment quality assurance can be subjective or delayed. For example, daily or weekly cone beam CT or EPID imaging, they have no real-time quantifiable indicators. So it forces a purely subjective review by the physician. And often that subjective review is happening on the fly while the patient is on the table. Chances are the physician's somewhere else in a consult with another patient, had to step away. They're really not able to spend the time. It's hard to fit that into their workflow. So, moreover, weekly physics chart reviews can lead to potential delayed reactions to issues, so that they're not happening real time, they're happening days later after treatment. So any changes with associated anatomy or weight changes may not be caught after some delay. And again, this is a qualitative review. It's subjective, and in many cases, it can be beyond the scope of a physicist's expertise. So they're looking at the patient chart more closely, but they might not have the expertise to evaluate some of these things. So really, you know, being able to look at the treatment field for every fraction and have the physicist immediately alerted to any deviations, you really can't get any more responsive to that.
No, this is great.
Let me go here. So Adaptivo's in vivo verification module really does just that. It provides daily exit dose tracking using the EPID while the patient is on the couch receiving their daily treatment. It has the ability to capture setup and delivery errors, plus changes in anatomy that affects dose, such as weight loss or a change in tumor size. There are two modules or modes with in vivo verification. We have the predicted mode, which requires an adaptive beam model, which is used to predict the expected transit dose at the EPID. And then we have a relative mode. So this is where you could, the user could select a reference image that's then used for subsequent comparisons. So let's say your first fraction is an ideal fraction to use for comparison. It's most likely very similar to the patient's CT in terms of anatomy and weight. So you use that moving forward. So in each of these cases, a gamma comparison is automatically completed for every treatment field as soon as the patient's treatment is complete. So as you can see here, there's an image on the right, and that shows a summary of the analysis for each treatment and each treatment field within that. The gamma results are displayed at the bottom of each of the EPID image comparisons. You see the color corresponding there. Green meaning passing results, yellow is a warning, and red represents a failing result. And of course, these are all configurable within the clinic. But the best way to really illustrate the usefulness of this, because you might ask, how can a physicist really use this information to evaluate the underlying cause? So the best way is really to look at a clinical example. So I'm going to show you some data from one of our customers, Brian Pomaget, who is with Genesis Care. I'm going to help demonstrate this. So here we have a case study. It's a lung treatment, a lung plan. We're looking at the treatment cone beam CT, but the contours that are shown are from the treatment planning CT. So as you can see, things have changed some. Looks like the patient has likely lost some weight. The tumor has regressed. Patient had fluid in their lungs during their treatment planning CT, but that has since cleared. So for a physician looking at this, they might not immediately clue into the fact that, there may be a dosimetric impact on this. Like they may just kind of say, okay, seems good to go, that the tumor's in the target still, and move on. But with daily in vivo gamma analysis, you can start seeing some of the consequences of these variations. So here I'm just showing on the right, I'm just showing the gamma analysis from fraction 31 to 37. And you can see around fraction 35, even though for ARC4 is always going to not be so great, fraction 35, all of the fields were starting to look off. So this would sort of be a good flag for the physicist to start investigating, or they might even be flagged earlier on just by looking at ARC4 to figure out, well, why is that off? Looking close at, say, fraction 35 for ARC4, you can see that red represents hotter areas, so more radiation has reached the EPID panel in that case, and that's because of the tumor regression and the weight loss. So that radiation is not being deposited in the patient as we want it to, it's reaching the panel, so something is different. Also looking at the profiles of the portal dose comparisons, you can see there is an absolute difference between measured and predicted. But I love this view because really it's giving you a great view of looking at the trending of all this, because when we just look at snapshots, it's really hard to make sense of what it means. But looking at a trend over time, we can see the patient was, the treatment was excellent through a good majority of their fractions, but maybe somewhere around, I don't know, fraction 25, 26, after fraction 26, things started veering off. So very likely at that point, the treatment was actually having an effect. Tumor was regressing, the fluid in the lungs was clearing. You know, side effect is they're losing some weight. And we can see that this is impacting the delivery. So this is a really good tool to be able to assess when you may be required to adapt your treatment, to get the patient back to CT simulation and run through that a new plan and start fresh. And you don't want to, you know, be too reactive to this, because it is a lot of work for the entire clinic to do that. Patients put on hold, but you do want to understand the effects of continuing with the treatment delivery as is. So this really, really helps that way. So that's basically a very high-level overview of our comprehensive patient QA solutions here at Standard Imaging. And thank you for listening, and we'll open it up to any questions you may have.
Yeah, I'm not seeing any questions at the moment.
All right.
So if you do have any questions from our audience here, please feel free to pop them into the question box and we will address them. And this was a very high level overview, but so informative. Thank you so much, Vicky, for taking time to share these things with us and be willing to kind of address some of these risk management issues.
Yeah, you're welcome. I know it's a lot of information, but hopefully it's all very useful and kind of gives people a wider sense of what patient QA really can entail, and not just the traditional view of patient QA. So,
absolutely. It looks like we do have a question here. Have there been any studies as to the effect of the dose on the EPID?
In terms of the damage to the EPID, is that what I'm assuming that's what they're referring to. I'm not aware of any studies. I do know EPID panels are a lot better than they used to be. You know, years ago when they first came out, you might get a few years out of your panel before you start seeing dose, but you know, there may be times when you would see that it needs to be recalibrated. But it's still, once that calibration is done, it should be performing well. So that I can research that for the studies on the EPID performance. I'm sure they're out there for the different vendors. But again, they're much improved from past EPID panels.
Yeah, some additional information. Yes, 50 patients a day, and yes, damage.
Yeah.
So yeah, excellent. Thanks so much for your questions.
All right. Well, I appreciate everybody taking time to listen today, and this will be recorded, like we mentioned, so you can share and rewatch it.
Yes, so we'll be sending out recordings of today's webinar to all of our attendees, and as you can also check it out on our website, standardimaging.com. And if you do have any further questions, you can find also on our website access to your regional account manager, and through them you can schedule a more in-depth dive demo for any one of these pieces of software that we've overviewed today. Thank you so much, everybody.